Good evening, everybody, and thank you, Dr. Amila, for the introduction, and thank you very much to the College of Ophthalmology for inviting me for this talk as well. And I'm happy that I think our different specialities are thinking outside of their own specialities. I think it's important the way that the world is evolving. We need to be aware of, obviously, other issues that our patients obviously encounter themselves. And let me just start off my lecture. I don't have any conflicts of interest except for the fact that I'm a cardiologist and I like blood thinners. Yeah, don't hold me accountable for that. But yeah, I know it, much to the dislike of surgeons and ophthalmologists alike. That's something that everybody encounters in this day and age, where people have had heart issues, they're on blood thinners, they come to an ophthalmologist, and then we get blasted. But let me see if we can make some sense out of as to why we give it and what we can do to help as well, as far as cardiologists are concerned. But yeah, I always try to start my lectures when I do so with a quote from somebody. And William Osler is somebody I quote a lot on, because he's obviously he's considered the father of modern medicine. I'm sure you'd have heard about him. He was one of the founder physicians of the Johns Hopkins University in the US. And he has multiple quotations, but one of my favorites is that he says to care more particularly for the individual patient than the special features of the disease. And I think that's important, isn't it? We sometimes get carried away with a certain disease and we forget the fact that this is a patient we are dealing with, and the patient may have multiple problems and multiple diseases on its own right, and we need to tackle everything individually. But sometimes these diseases do overlap with each other, and sometimes we have to discuss amongst each other, for example, as ophthalmologists and cardiologists, to figure out what's best for the patient at the end of the day. So that's important. I think we sometimes focus too much on the disease and we forget the fact that this is an individual, a patient, a person. And I think it's important to kind of realize this as well. So the good thing about Sri Lanka is that our overall life expectancy is getting better. That means essentially people are going older and older and more people are living. So essentially we have a very geriatric population nowadays. You can see from the 1960s onwards, where the life expectancy average was about 60. In the current era, 76. So that's quite a massive jump, isn't it? So we have a massive good, and that's I think that's a good, obviously that's a basically a pat on the back to our healthcare system, essentially, that our healthcare system is developed so well that despite all the circumstances, all the struggles and everything that's going on, resources, etc., despite all of that, our patients are living longer. And living longer means that obviously they are aging as well, but that's important, because the reason is that this is something I think I couldn't find any data in Sri Lanka, but I'm sure we can extrapolate this as well. As people get older, their diseases also progress as well, and obviously the older the people, so for example, if it's eye disease, this is something from Korea, and I think it's probably the same. When patients get older, the incidence of diseases get more and more as well, and more prevalent. So for example, cataract from eye disease is why macular degeneration, glaucoma gets more prevalent as patients go older. And it's the same for cardiovascular disease as well. And you can see as people get older, I think there's just evidence, but I think we all know this as well. As people grow older, the incidence of cardiac disease also goes older. So it's something that we encounter. So we encounter so many, a huge geriatric population nowadays in Sri Lanka as well, and I can extrapolate this to Sri Lanka. And because of that, the amount of patients who have cardiac disease and eye disease, and the combination eye and cardiac disease will be more and more. And as people of medicine, we will encounter these type of patients more often than not as well. So I thought maybe change the title of the talk to heart disease complicating ophthalmology, or cardiologists complicating ophthalmology. That might be a bit more relevant to you guys. I think you might agree with me on this. Sometimes we kind of do complicate things for ophthalmologists. So I just thought I kind of prefer to talk on cases and kind of case-based, if I may. So I'm not going to talk about a lot of cases, but just one person. I think this is somebody who we all may relate to, as you also probably would have encountered certain patients like this. Again, an elderly man, 78 years, background of diabetes, hypertension, ischemic heart disease. He's coming to the ophthalmologist with visual impairment. So I think that's a common presentation, isn't it? But this is where it gets a little complicated. So a month ago, he had a myocardial infarction. He required angioplasty with a stent. So stent means, obviously, you know what he's on. His LV function is a bit low, 45%. And on top of that, he also has got an aortic stenosis. So again, this is a common, I think, as I said, aging population, common scenario. Then it gets better. He also has atrial fibrillation. So he's got an arrhythmia on top of everything as well. For you guys, for the ophthalmologist, he's got cataracts, and it's impairing his quality of life, and you probably need to replace that lens or lenses on both eyes. And he's on the following medication. This is where you guys love us. So he's on aspirin, he's on clopidogrel, and he's on rivaroxaban. And I think everybody knows what rivaroxaban is. It's a direct oral anticoagulant. So he's on 3 blood thinners. And he's on statins, etc., etc. So as you have seen in your clinics, that patients with heart disease will be on multiple medications. But the ones that are important as far as the talk is concerned are the first 3, I suppose, isn't it? So he's on 3 blood thinners, 2 antiplatelets, and rivaroxaban. There is a method to our madness, though, here. The patient probably required, or not probably, did require all of these medications. In particular, he's got a heart attack, he's got a myocardial infarction, he's got a stent. So if he's got a stent, he needs to be on dual antiplatelets, aspirin and clopidogrel. And he also has got atrial fibrillation and arrhythmia that potentially can lead to blood clots, leading to strokes, etc. So to prevent that, unfortunately, antiplatelets alone are not enough. So this patient will require an anticoagulant. So in the good old days, it was warfarin. I'm talking good old days as if I'm an old guy myself. But yeah, even in my student days, we used warfarin a lot. But now we have the modern or the newer oral anticoagulants, rivaroxaban, apixaban, dabigatran. You may have heard about them as well. But this patient warrants treatment with a anticoagulant as well because of his background atrial fibrillation. So that's where the problem is. So this is what you guys are like that now, isn't it? In your head, like, oh gosh, what am I going to do? So how can we help? So I think this is pretty much the gist of my talk today as to how can we as cardiologists help ophthalmologists in kind of managing this patient and sorting this patient so that we can, again, as I said, we need to always think of what is in the patient's best interest. And I think as far as the surgery is concerned, cataract, it's going to impair his quality of life. It needs to be sorted. But can it be done? Can it be done? And when can it be done? That's going to be the questions that we need to answer. So the first question that the ophthalmologist is going to ask me and ask us is that, is the patient fit to undergo the surgery in the first place? So let's see if you can come up with a good answer for that. So the next question they ask is, if he is fit to undergo surgery, can the patient stop, or does he need to stop these antiplatelets and anticoagulants before the surgery? So that's something, again, debatable, I suppose. It's something that I always question whether, for example, something like a cataract, does the patient actually need to be off blood thinners, antiplatelets before the surgery? But we can obviously go a little expansion on that and talk a little ahead of, or rather different to cataract surgeries, any eye surgery, as to when they need to stop it and how long before. And probably the more important one, as cardiologists, can we help surgeons like ophthalmologists or any other surgeon who require surgery to kind of we optimize the patients a bit better? Are there any new advances that we can utilize as cardiologists to help surgeons to not tear their hair off? So to talk about fitness of surgery, I think this is pretty much the way of life as well, isn't it? To do anything, to proceed with anything, we need to balance the risks and benefits, and that's pretty much the bottom line. If the benefit outweighs the risk, we go ahead with it. If the risks outweigh benefits, then we don't proceed. Essentially, that's the bottom line. So for any surgery, ophthalmology or otherwise, it's a fine balance, but then we need to discuss, we need to investigate, we need to check to see what is more, whether the benefit is more or the risk is more. And this is a fantastic paper that I read in the British Journal of Anesthesiology, Anesthetists. Basically, it gives a nice overall picture of how you manage patients prior to any non-cardiac surgery. It's a nice paper. You can get it online as well. But I think the summary was important. So the ultimate goal of preoperative cardiovascular management is to improve overall patient outcome. I think that's very, very important, isn't it? We need to, and that's something that sometimes we forget, that we are doing all of this to hopefully improve this patient's overall outcome. So whatever we do, whatever we decide on, at the end of the day, should help this patient get through and obviously have a better quality of life. So again, individualized management. So that's what they focus on. It's not about treating the disease. It's not about something we are sometimes lose focus of. It's about, and different persons, different people, we have to manage differently. So we need to take each patient individually and come up with a plan. And obviously it involves the detection and management of cardiovascular disease and prediction of that short and long-term cardiovascular risk. So there are different methods that are done. And obviously that means that not only affects that anesthetic perioperative management, but also surgical decision making. So you guys, it's as I said, it's kind of a multimodal. We need to have multidisciplinary team meetings and decide as to what is best. So anesthetists, ophthalmologists, for example, in this circumstance, and cardiologists in that certain circumstance as well, to come to a collective decision as to whether this patient will be safe to undergo any procedure. And that word is important, isn't it? Safety. I think that's something that we kind of miss sometimes as to our patient management. To any patient, that's important as well. If you tell your patient that they're going to be safe doing this, they'll be happy as well. So surgical risk is kind of classified in many ways, and low, intermediate, and high risk categories, but eye surgeries, thankfully, so far fall into a low risk category. So that's important. Anyway, from a patient's point of view, they feel happy as well that eye surgeries are considered a low risk surgery in the first place. And how do we assess if your patient is at high risk or not for any surgery, including eye surgery? So there are different assessment tools. So this is the so-called Lee index. You can again find it online. There are different parameters that you look at and see if the patient is undergoing any of these high-risk surgical procedures, if they have a history of ischemic heart disease, like our particular patient, history of heart failure, CVA, treatment with insulin, etc., and you give a point for each, and then classify them as to what type of risk this patient may be on, having rather for a particular surgery. The good thing about ophthalmology is that majority and an overwhelming majority of surgeries in ophthalmology are done under local anesthesia. I think that's important. I think you will agree with me on this. In particular, cataract surgeries, in the UK, for example, 95% of cataract surgeries are done under local anesthesia. You probably can educate me in Sri Lanka as to how it is, but I think it's probably the same. And mostly, again, topical anesthesia is used, that's good. And even for other surgeries, including vitreoretinal surgeries, in the UK, there is a bit of a trend now that they're moving away from general anesthesia and moving towards more local and regional anesthesia, which is good. So essentially, when a patient is undergoing surgery under local anesthesia, the risk of any complications, cardiovascular or otherwise, will be less. However, there is a certain amount of toxicity from local anesthesia as well, which we need to understand, and you can it's called LAST, local anesthetic system toxicity. If it gets into the system inadvertently, it can lead to complications, including cardiovascular toxicity. You can see here, heart conduction anomalies, and in particular, ECG changes. So PR interval prolongation, QT interval prolongation, which leads to different arrhythmias in your patients as well. So important to know that that local anesthesia, although safe, I suppose, in inverted commas, compared to general anesthesia, potentially, if it's given in a wrong technique, I suppose, can potentially cause complications as well. So how do you prepare your patients for a surgery as far as any cardiac investigations are concerned? So there are a few things that we do, but do all patients require all these tests? So for example, I know we get referrals as well from surgeons and ophthalmologists as well for cardiac risk evaluation, and they say to get an ECG done, etc. So it depends on from person to person. Again, this is what I mentioned as individualized approach. So essentially, for example, on the top there is an electrocardiogram, an ECG. Does everybody need an ECG? Not really, unless they have some previous cardiac symptom or any cardiac history. And ECG is also not necessary. It's particularly undergoing low-risk surgeries such as eye surgeries. And echocardiogram is the same. Unless the patient is undergoing a high-risk surgery, getting an echocardiogram done is not necessary unless the patient has multiple cardiac risk factors and symptoms. So this is something that we can probably change as well, because not all patients undergoing eye surgeries, especially asymptomatic patients, even if they are older, will not require all these investigations. You can proceed, especially if it's a low risk under local anesthesia, topical anesthesia. So the next question that's asked from us is whether their antiplatelets can be stopped or not. So again, stopping antiplatelets is a balance between the risk of thrombosis and the risk of bleeding during surgery. And can we stop these antiplatelets? So again, depends on how risky this business is as to how it's stopping antiplatelets. As I said, we have a method to our madness, so patients will undergo stenting, for example, and if it's within the first 8 days of a stent, stopping antiplatelets carries a very high risk. And the risk is still high up to 30 days. After 30 days of implanting, especially the newer generation drug-eluting stents, as we call them, the risk gets a bit lower. It becomes moderate, and then so on and so forth. So general recommendation is if a patient has a heart attack and undergoes angioplasty with a stent, within that first 30 days, stopping antiplatelets is going to be risky. But the good thing again is that the bleeding risk as far as surgery is concerned is less in ophthalmology surgeries. And this is from European journal as well, that as far as interventions are concerned, thankfully, ophthalmology surgeries, including cataract glaucoma interventions, for example, carries a low bleeding risk. So that's why the balance is important. So if the ophthalmologist thinks that they can perform this surgery without any bleeding complications, stopping blood thinners, particularly in a patient who is on antiplatelets, may not be necessary. I'm just going to skip that because I think I'm running out of time. So just a couple of more slides. So how do we optimize this patient and how do we use these new advances? So this is what I mentioned as cardiologists, how can we help? So I think it's important to avoid physician inertia. I think it's something that we do as in the clinics. We see so many patients come to us, we write the same prescription, continue same, and we see that they're on all these medications unnecessarily sometimes. So for example, they're on antiplatelets, blood thinners for years and years and years, and sometimes there's no real indication for that as well. So I think we need to look into that a bit more. And discontinuation of these antiplatelets when recommended. So that I'll talk about a bit later as well. And patient in heart failure also, if they're going to undergo surgery, they should be optimized. And I'll touch a little bit on these novel therapies that potentially can help to minimize the duration as to what these antiplatelets and anticoagulation should go for. So the default or standard recommendation for antiplatelets and DAPT, that's dual antiplatelets, aspirin, clopidogrel, and other antiplatelets. So there is a change in the guidelines as well. But so basically in patients who've had procedures for stable heart disease, stable ischemic heart disease, the recommendation now is 6 months of dual antiplatelets. So patients, if they had a PCI, angioplasty, after 6 months, dual antiplatelets can be stopped and they can be put on a single antiplatelet only. If a patient has an acute coronary syndrome, though, general default dual antiplatelet regime is 12 months. But that's default, but we can change that. So again, certain patients we find, I'm just talking out of surgery or ophthalmology or anything, but in cases, sometimes patients are at high bleeding risk. And if a patient is at a higher bleeding risk, we actually can stop these. And the latest recommendations using new generation drug-eluting stents, for example, is that we can actually stop these dual antiplatelets after 1 month. We can stop them after 1 month. So we can kind of extrapolate that into surgery as well. If a patient has to undergo some sort of a surgery and it's necessary, we can potentially stop dual antiplatelets at 1 month as well. So that's important, and we can have a discussion about that thrombosis and bleeding risk, and then potentially stop antiplatelets if needed at 1 month as well. But stopping them within 1 month may be a little tricky. But there are some strategies that we can help with to reduce the duration further of dual antiplatelets. So for example, these newer generation drug-eluting stents, there is some evidence that even less than 1 month potentially, there is research going on. And to obviously from our side, we try to keep it simple. If we have a simple percutaneous coronary intervention, the chances that we can stop blood thinners early is better compared to complex PCIs. And there's a new technology called drug-coated balloons, where rather than implanting metal scaffolds into the patient's coronaries, we do this drug-coated balloon inflation, and there is no metal, hence the risk of stent thrombosis. That's why we give them antiplatelets is less. So we can actually minimize the use of antiplatelets as well and potentially reduce it to even 2 weeks. So these are all upcoming. So drug-coated balloons is something that we are using now, but again, 1 month is what is recommended. But in the future, we are hopeful that even we can reduce that dual antiplatelet duration to even 2 weeks following drug-coated balloon angioplasty. And then there are some, for patients who have, for example, we are talking about coronaries, but then there are other patients as well. And for example, patients who have had valvular heart diseases. So again, the problem with valvular heart disease, if they have a mechanical valve, is that they are on, again, anticoagulation, and in particularly warfarin. And again, that can be a little cumbersome for us, to bridge with heparin, etc. But newer techniques such as transcatheter techniques of valves, so TAVI is something that you may have heard about, transcatheter aortic valve implantation. So in this instance, a patient who has severe aortic stenosis or aortic regurgitation gets a transcatheter valve, and that doesn't require any anticoagulation in the form of warfarin. They just need to be on aspirin only. Similar is a procedure called mitral clip, where they do a transcatheter clipping of the mitral valve in patients who have mitral regurgitation. Again, no mechanical valve. They do not need anticoagulation with warfarin as well. And if they do require a valve replacement, we potentially can put them on bioprosthetic valves, which requires less duration of anticoagulation. So in summary, ladies and gentlemen, I think an aging population means more cardiac and ophthalmological diseases. But again, as I mentioned before, cooperation between the specialties is essential for that optimization of the patient before procedures. I think that's something that we need to focus on and improve on. Balancing the risk and benefit before any procedure is important, and that will help to obviously for the patient's point of view as well. And as cardiologists, what I can suggest is that we should try at least to utilize novel therapies that will minimize the use of certain medications that you guys get annoyed with when we use. Thank you very much.